Welcome. In this session, we are going to start our discussion of infectious uveitis, and in this session, we are going to talk about syphilis, a spirochetal infection which is a great masquerader of any possible form of uveitis and should be considered in almost all uveitis presentations. We'll also be discussing in this session two other spirochetal disease, Lyme disease and Leptospirosis. When considering an infectious etiology of an uveitis presentation, we should take a history of exposure from a possible contact or other sources in an endemic region. An investigation of a possible infectious agent is directed toward detecting the possible etiologic agent, in addition to detecting morphological and functional abnormalities of the eye and other systems, as is done in non-infectious uveitis. And treatment of infectious varieties of uveitis includes antimicrobial therapy to eliminate the etiologic agent and anti-inflammatory therapy to control inflammation simultaneously with the antimicrobial therapy to control the infection, because inflammation per se can cause the ocular damage. And anti-inflammatory therapy should always be under cover of effective antimicrobial therapy in infectious uveitis. The possible etiologic agents of infectious uveitis include bacteria, virus, fungus, protozoa and helminths, and we'll start with the bacterial causes in this session, and we are going to discuss syphilis, Lyme and Leptospirosis, the three important spirochetal infections causing uveitis. Syphilis, as we have mentioned, is a great masquerader and needs to be ruled out in all forms of intraocular inflammation, and it is caused by the spirochete Treponema pallidum. Transmission is by sexual contact, and another possible route of transfer is transplacental transfer, causing congenital syphilis, but this usually occurs after 10 weeks of gestation. Early and appropriate antimicrobial therapy for syphilis can reduce visual morbidity and also prevent neurological and cardiac disability from syphilis. So early detection of syphilis is all the more important. So we will be discussing two forms of syphilis: congenital syphilis starting early in life and due to transplacental transmission, and acquired syphilis starting later in life and usually due to acquisition from a sexual contact. So congenital syphilis occurs from a transplacental transmission and is more common if the mother develops primary or secondary syphilis during pregnancy. So the longer the duration of syphilis in the mother, the less the chance of transplacental transmission to the fetus. And congenital syphilis can be early congenital syphilis or late congenital syphilis. Early congenital syphilis usually starts before 2 years of age, and systemic manifestations of early congenital syphilis include hepatosplenomegaly, pneumonia, severe anemia and skin rash. Ocular manifestations of early congenital syphilis include multifocal chorioretinitis with or without retinal vasculitis, and upon healing, fundus appearance is called salt and pepper fundus, and following healing the pattern remains stable, and in some cases it may not actually affect vision significantly. Another ocular manifestation is RPE degeneration with vessel attenuation and optic atrophy, and this pattern resembles retinitis pigmentosa. Late congenital syphilis starts after 3 years of age, and systemic manifestations of late congenital syphilis include Hutchinson teeth, that is notched incisors, mulberry molars, hard palate perforation as shown here, severed shins as depicted in this picture, raggeds, that is folds on either side of the mouth, cranial nerve 8 deafness, neurosyphilis. However, cardiac involvement is unusual. Up to 50% of patients with late congenital syphilis can have ocular manifestations, and the ocular manifestation can occur many years later, and the primary ocular manifestation of late congenital syphilis is interstitial keratitis. Please look up on the internet for a picture of interstitial keratitis from congenital syphilis, because I could not find a non-copyrighted image. So in interstitial keratitis from congenital syphilis, we get a dense corneal haze with deep vascularization called a salmon patch appearance, and also ridges in Descemet's membrane in the early stage. Later on, there is corneal opacification, and the deep vessels which grow into the cornea later on appear as ghost vessels without blood. Interstitial keratitis may be associated with anterior uveitis and glaucoma, and there is this very well known triad called Hutchinson triad of interstitial keratitis, Hutchinson teeth, and cranial nerve 8 deafness. Now coming to acquired syphilis, which is usually acquired through sexual contact, and the systemic manifestations of acquired syphilis occurs through 4 phases: primary, secondary, latent, and tertiary. The incubation period after infection is usually 3 weeks, after which the primary syphilis starts, and we get a painless solitary chancre at the site of inoculation. Inoculation rarely occurs through conjunctiva, and we may find a conjunctival chancre as a round lesion with surrounding erythema without much discharge, and the chancre in the primary inoculation site usually resolves within 12 weeks. The next phase, secondary syphilis, usually starts 6 to 8 weeks after the primary infection and occurs in 60 to 90% of those having primary syphilis. And the systemic features of secondary syphilis include lymphadenopathy and a generalized maculopapular rash, which is usually prominent in the palms and the soles. Uveitis occurs in 10% of patients. After the secondary phase, the latent phase starts, and it can last from a year to several decades. And the final stage of acquired syphilis is tertiary syphilis, which can occur in 1/3 of untreated patients of syphilis. The systemic features of tertiary syphilis are gummatous lesions in the skin, mucous membrane, and even in the iris and the choroid, neurosyphilis, cardiovascular syphilis, and uveitis occurs in 5% of patients with tertiary syphilis. As we have mentioned, syphilis is a great masquerader and can involve any structure of the eye from the conjunctiva to the cranial nerves. An intraocular inflammation can be unilateral or bilateral, granulomatous or non-granulomatous. Anterior segment involvement is the most common form of uveitis in syphilis and includes lesions such as iris roseola, which are small vascular lesions of the iris gummata, interstitial keratitis like congenital syphilis, and complications such as posterior synechia, cataract, glaucoma, lens dislocation, and iris atrophy. Posterior segment involvement with syphilis includes solitary or multifocal chorioretinitis, which is the most common manifestation of syphilitic posterior uveitis. And in the multifocal variant, we get small yellowish lesions in the post-equatorial fundus in the posterior poles. However, a solitary form called posterior placoid pigment chorioretinitis is considered pathognomonic of secondary syphilis. So this is the placoid form of syphilitic chorioretinitis. In fluorescent angiography, we get early phase hypofluorescence and late phase hyperfluorescent staining, often called a leopard spot hypofluorescence, and ICG shows hypocyanescence. OCT shows disruption at the level of RPE and outer retina. So this is another picture showing placoid chorioretinitis involving the fovea and the area of the retina temporal to the fovea, and this is reflected in the fluorescent angiogram. Retinitis and retinochoroiditis can also occur, and this may resemble viral retinitis such as acute retinal necrosis or progressive outer retinal necrosis, but retinitis from syphilis usually progresses slowly in comparison to viral retinitis, and these retinitis lesions may become confluent. Associated vitritis is usually found. Vasculitis can also be seen and can affect both arteries and veins, and may resemble a BRAO or a BRVO. Exudative retinal detachment can also be found. Neuroretinitis or papillitis from syphilis is more common in immunodeficient states, and in immunodeficient states there is a tendency for the lesions to recur even after appropriate treatment. And in tertiary neurosyphilis, we may find retrobulbar neuritis, optic neuropathy, cranial nerve palsies, and Argyll-Robertson pupil. So the gold standard of diagnosis is direct visualization of the spirochete, and that is possible only from lesions of primary syphilis. And this is done either by dark field microscopy or fluorescent antibody test of secretions from the primary syphilis lesion. Syphilis serology can be done with 2 types of tests. We have the non-treponemal tests and the treponemal tests. Non-treponemal tests detect anti-cardiolipin antibodies which are elevated in syphilis, and the two common non-treponemal tests are the Venereal Disease Research Laboratory or VDRL test and the Rapid Plasma Reagin test or RPR test. Titers in non-treponemal tests increases in primary or secondary syphilis and decreases in latent syphilis and after treatment of syphilis. This is important to remember because it can be used to monitor response to therapy. That means after appropriate treatment of syphilis, VDRL and RPR titers should come down. False positive results on non-treponemal tests can occur in many conditions. The treponemal tests detect anti-treponemal antibodies, and the older treponemal tests include FTA-ABS fluorescent treponemal antibody absorption test, MHA-TP or microhemagglutination assay, TPHA treponema pallidum hemagglutination assay, and TPPA treponema pallidum particle agglutination assay. They are more specific with similar sensitivity as compared to non-treponemal tests, and they are conventionally used to confirm a positive result on a non-treponemal test. Now there are newer varieties of treponemal tests, enzyme immunoassay and chemiluminescence assay. In comparison to the older treponemal tests, they have higher sensitivity but lower specificity, and they are currently recommended as screening tests, and they should be confirmed with a non-treponemal test which is called reverse screening, and it is found that such a protocol saves time and cost. Anti-treponemal antibodies start rising in secondary syphilis and persist throughout life, so they do not come down after appropriate treatment of syphilis, and so they are not useful in monitoring response to therapy in contrast to non-treponemal titers. IgM FTA-ABS is used to diagnose congenital syphilis. False positive results are much less common in treponemal tests in comparison to non-treponemal tests, but may be found in systemic autoimmune disorders, HIV, malaria, leprosy, Lyme disease, Leptospirosis, and advanced age. Lyme disease and Leptospirosis are the two other spirochetal diseases we are going to discuss shortly, and it is recommended that both non-treponemal and treponemal tests be done for a patient suspected of having syphilis. A CSF examination should be done in every case of syphilitic uveitis because syphilitic uveitis is considered as a manifestation of neurosyphilis, and a positive CSF VDRL or a CSF FTA-ABS and or positive CSF pleocytosis is diagnostic of neurosyphilis, and this needs to be repeated every 6 months for monitoring relapse of neurosyphilis. PCR testing of intraocular fluids, skin lesions and CSF can also be done, and HIV testing should be done in every case of syphilis to rule out HIV co-infection, because HIV can be associated with both a false positive syphilis serology as well as aggressive manifestation of the syphilis disease itself. Screening of sexual partners is also recommended. Syphilis being an infectious uveitis entity, treatment is two-pronged: antimicrobial therapy and anti-inflammatory therapy, and penicillin is the antimicrobial drug of choice against syphilis. For adult syphilis, intravenous aqueous crystalline penicillin G 3 to 4 million units should be administered every 4 hours for 10 to 14 days, and this may be supplemented with weekly intramuscular benzathine penicillin for 3 weeks. Alternatively, intramuscular broken penicillin can be administered daily with oral probenecid. Congenital syphilis is also treated with intravenous aqueous crystalline penicillin G, and the dosage is 0.05 million units per kilogram every 12 hours in the first 7 days of life and 8 hourly in the next 3 days, and a 4 to 8-fold decrease in non-treponemal test result within 3 to 6 months confirms treatment efficacy. But this may not hold for HIV patients who may have abnormal serology results. Jarisch-Herxheimer reaction is an allergic reaction to released antigens from killed spirochetes, and it occurs during the first 24 hours of initiating treatment and is manifested by fever, hypotension, tachycardia, and with worsening of the intraocular inflammation, and treatment of this reaction is with systemic steroids. If the patient is allergic to penicillin, penicillin desensitization can be done before administration of the drug, And alternate drugs include tetracycline, doxycycline, ceftriaxone and chloramphenicol, but they are much less efficacious. And the other aspect of therapy should also be taken care of, that is the anti-inflammatory therapy with topical, local and systemic steroids, and this should be under cover of appropriate antimicrobial therapy. And the prognosis is usually good if treated promptly. Another spirochetal infection is Lyme disease, and the name Lyme comes from a town in the United States. And Lyme disease is caused by species of Borrelia, and the species most commonly involved in United States is Burgdorferi. But it has been reported from all other areas of the world, and other species of Borrelia are responsible for the disease in other areas of the world. It is transmitted by tick bites, and these ticks are harbored in animal reservoir. The presentation of the disease is classified into 3 stages. In stage 1, which occurs within 4 weeks of exposure to tick, erythema chronicum migrans is found at the inoculation site, and this is the pathognomonic lesion and is very important for diagnosing the disease. So this is an erythema chronicum migrans lesion with a typical bull's eye appearance, and this can be associated with fever, malaise and arthralgias. Ocular manifestation in stage 1 is not that serious and includes follicular conjunctivitis and episcleritis. Stage 2 occurs within 4 months of infection and is characterized by arthritis of large joints, especially the knee. Patient can also have meningoencephalitis and Bell's palsy. This is important to remember, and this can be unilateral or bilateral. Erythema chronicum migrans can be found in stage 2 beyond the inoculation site, and there can also be cardiac conduction defects. Ocular manifestation of stage 2 Lyme disease includes intermediate uveitis, the most common manifestation, and this may be associated with peripheral multifocal choroiditis. Other manifestations of Lyme disease can be protean. In stage 3, which occurs beyond 5 months of infection, the patient also complains of arthritis, and neuropsychiatric symptoms predominate, including memory loss, radiculopathy and peripheral neuropathy. A skin lesion called acrodermatitis chronica atrophicans may also be found in the extremities, and this results in thinning and scarring of the skin. Ocular manifestation of stage 3 of Lyme disease is bilateral stromal keratitis, and other manifestations of intraocular inflammation is uncommon. So stage 1 of Lyme disease is manifested by erythema chronicum migrans. The ocular manifestations in the second stage include unilateral or bilateral 7-nerve palsy and intermediate uveitis, and in the third stage of Lyme disease we get bilateral stromal keratitis. Diagnostic modalities for Lyme disease includes ELISA for IgM or IgG antibodies, followed by an Western blot assay, but this serological test has not been standardized. PCR analysis for the organism can be done, and CSF analysis should be done in patients with intraocular inflammation. Antimicrobial treatment for Lyme disease includes amoxicillin, doxycycline and cefuroxime acetyl, and Jarisch-Herxheimer reaction can occur as in syphilis. And steroids may be given under antibiotic cover, but it has been shown that it increases the risk of relapse of the manifestations. The third spirochetal disease which we are going to discuss is leptospirosis, and it is caused by the spirochete Leptospira interrogans. The organism chronically infects animals and is excreted in the urine of animals, especially rodents. And exposure occurs upon contact with soil or water contaminated by urine of infected animals. Leptospirosis has a worldwide distribution, mostly in tropical and subtropical areas, and groups which tend to be affected more by leptospirosis include agricultural workers, sewer workers, military personnel, veterinarians, slaughterhouse workers, and from recreational exposure. Following an incubation period of 2 to 4 weeks, leptospirosis has 2 phases, the leptospiremic phase and the immune phase. In the leptospiremic phase, there is fever, myalgia, headache, vomiting and diarrhea, and severe infection causing septicemia in leptospirosis is called wild disease, which manifests with renal and hepatocellular dysfunction, which can be fatal. In the later immune phase, there can be high fever, meningismus, myelitis and cranial nerve palsies. Ocular manifestations can occur in both the leptospiremic phase and the immune phase, and circumcorneal injection with or without subconjunctival hemorrhage is the earliest and most common manifestation. Most common posterior segment manifestation of leptospirosis is retinal vasculitis, and panuveitis can also occur. If we suspect leptospirosis in a patient, from history and examination, ELISA for IgM antibodies should be done, and this test has a very high sensitivity and specificity. An antibiotic treatment for leptospirosis includes intravenous penicillin G in cases of severe disease or oral doxycycline for a milder disease. Steroids should be given as required but under antimicrobial cover. Thank you for listening.